Hi, everybody. We're going to get started. People will always join a little bit as we go along. And then we find mostly it's very helpful to have the recordings of these webinars that people can then also watch in their own time. So we are actually already in week 7 of rural onboarding. And this week our focus is specifically on adult medicine. And tomorrow, the next day, I'll be sending out the resource pack for adult medicine as well. And we are very pleased to have Professor Andy Parrish as our speaker tonight. And it's sort of also personally, I would like to almost do an ode, if I could, towards Prof, because Prof is retiring in, I think, 10 days from now. So it's his last month, and it's sort of one of his honorary lectures to have him speak to us this evening. He's an associate professor in internal medicine at Walter Sisulu University, as well as an honorary associate professor in internal medicine, clinical pharmacology, UCT. And he's also the co-chair of the National Essential Medicines List Committee, the chair of the NEMLC COVID Committee, and he has real interest in EBM and knowledge translation, and has been extraordinary in his commitment towards the training of junior doctors, especially in the more rural areas. So him, together with Dr. Dave Stead and Dr. Jenny Nash, has been responsible for a lovely project called the BAMSI program that's here in Amathole district and the BCM Metro in the Eastern Cape, but has already had sort of waves beyond these two districts as well. And I think partly due to COVID, they've become very active in actually having lectures, webinars that's been going out to the different district hospitals and CHCs. And every week there's a wide range of every week there's been a webinar, and all of these are recorded on the Medieval site. I'm hoping Andy will hopefully show you guys the link as well. Otherwise, I will put the link in the chat. So that's a very useful place where all of the webinars over the last 2-3 years have been recorded and uploaded on a wide range of topics, and very much tailored towards the district hospital and CHC doctors. So very worthwhile looking at. So we're very pleased that we have at least one last lecture from him, although I think we're going to be pulling him into the rural onboarding in the future. I'm sure we can bring him back after retirement. So thank you very much, Andy. I'm going to hand over to you.
Thanks, Madeleine. I'm just going to pop my screen share up. I hope it works. Let me know if it's working.
Yes, that's perfect. Well done.
Okay. Good evening, everyone. I'm not going to be terribly high tech here. So most of this is just going to be straightforward slides, one after the other. We have got one little video which you might want to look at, but mainly it's just slides. There will be a little bit of a question and answer thing. I'm not going to put anybody on the spot, so you can relax, but do try and think of the answers if there is a question up before I show it to you. It does help you solidify things in your own heads. So I'm going to go straight ahead now. Basically, what I've looked at is things that could count as tips in internal medicine. It's awfully difficult to think of things that we could cover in an hour and not leave a lot of stuff out. But basically, it's things that are easy to change, make a difference to outcomes, make a difference to your workload also, and are resource aware. And maybe we'll talk a little bit about risk reduction in terms of medico-legal load and obviously quality control. So the key thing with all this is thinking. And if you start to enjoy thinking about the stuff you do in internal medicine, it actually becomes a lot easier. It becomes faster, and it also becomes a whole lot more fun. So I've really put the theme around this, and we're going to run through the standard history examination type of things. But then I've also got a couple of slides on finding information, and ending up with a little bit about enthusiasm, which is sort of very close to my heart at the moment, but we can talk about that later if there's time. All right, so in history, the first one is a 25-year-old HIV negative woman taking treatment for TB for the last 2 months. She's got leg swelling now, shortness of breath, which she says is worse at night, and chest pain. And your differential, I hope, will include a few things. Now you can be thinking of that, but what we're going to be looking at is what are distractors and what are biases in terms of affecting how we think about her. So the first way of looking at this is to say, well, she's got TB and she's short of breath and she's got chest pain. Maybe she's had a pulmonary embolus, and you could wonder whether one leg is more swollen than the other. Did the shortness of breath start abruptly, and is she desaturating? And on the other hand, you could say, well, she's had TB for a couple of months and she's got swollen legs, and maybe she had pericardial TB as well all along, and it's now starting to constrict, and I need to look at her JVP, and I wonder if an ECG would help me. And the key thing here is that you weight your likelihood of those two things when you see her. If she wanders in and looks relatively well, you would think more perhaps of a pulmonary embolus. If she is, on a stretcher and has lost weight and is bedbound, you might think that it's more likely she's got pericardial constriction. But both are possible, and you can't sort it out just by looking at her. You do need to control these things with thinking about those two things. But having them both on board, thinking about malnutrition as well, are all things that would be important. So generating a differential is fun. If you're not sure what to choose, try alternative scenarios. What if it is this? And then think about something else. And does that fit better? And is there a third or fourth or fifth option? And then the key thing is to find those two diagnostic things and write them down. If you don't write them down, they sort of drift out and you forget about them. So if you put them down, you'll be amazed at how often you use them once you've written them down. Or the person seeing the patient in the ward the next day might use them as well. But if they're not there, everybody just thinks it's the most likely thing, and this is why. And it's all about things called heuristics, which are basically shortcuts we do in everything in medicine and in our daily lives as well. They can be very helpful, or they can bias the way we think about things and cause problems. So there's a whole bunch of these things. The common ones are availability heuristic. We tend to think of things that occur commonly, or that pop into our heads commonly, and we tend to anchor things with the presenting symptoms. So if we've just seen somebody who's had TB and diagnosed, and they had a cough and shortness of breath, and somebody comes in with cough and shortness of breath, we're more likely to think it's also TB than that this is now a pulmonary embolus or heart failure. And then the other major bias that we suffer from is called confirmation bias, where we look for information that confirms what's wrong rather than what refutes what's wrong. So we can talk about that later, but basically, if you can think of a single physical sign, we'll come back to this, but for instance, in a patient with ascites and a history of drinking and all that, the refuting sign is looking at their neck, and if their JVP is up, that would be far more helpful than finding out more information about their drinking habits. So the next one then is a 20-year-old lady with persistent upper abdominal pain, and this is where these biases can take you astray. She has pain that she says is a little bit worse when she eats, and she's been treated twice in the last 3 weeks by various folk for gastritis and or peptic ulcer disease, and she's ambulant, and when you touch her tummy, she's got mild epigastric tenderness. So your brains are now saying, complicated ulcer, I wonder what else is going on. But try this for size. That's her chest x-ray, and that's clearly abnormal. And if you look in the middle, just above the heart itself, in the area of the aortic arch, you'll see something fishy is going on there. And if you look at her CT spine, you can see that she had tuberculosis of the spine with a basically preserved disc and a destroyed vertebra, and was one of the luckiest patients with TB spine I've ever seen, in the sense that she presented with referred epigastric pain from that thing and had no focal long tract neurology. She walked in and walked out of our care. And it really was a sort of wondrous thing, but it was so close to being a collapsed thing, as you can see from that middle picture. So think of the other things. It mustn't always be common things occur commonly. And referred pain is important. If you have a paraplegia or a sensory level, you need to look at the thoracic X-ray and not the lumbar spine. Remember, the cord ends in the thoracic area, and X-raying the lumbar spine is not going to help you resolve issues of why somebody can't walk if their legs are paralyzed. Look at the films carefully, and if you think it's nothing much going on, but it maybe you think it could be TB, think about doing a CRP or some other measure of inflammation before just dismissing this as non-tuberculous. And obviously don't forget the syphilis serology. So referred pain is important. There's stories of people having syphilis-related arachnoiditis for more than a decade because nobody thought of it. So do think of these things. They do happen, and syphilis is particularly common at the moment compared to a few years ago. Right, let's move on a little bit and talk about examination. And the next patient has got a known mitral regurgitation. She's 35. She had a dental abscess with a tooth extraction 6 weeks ago, and she's tired and has lost weight and has night sweats. Now, which of these two features would you look for in examining her hands? Would you look for splinter hemorrhages and clubbing, pallor and clubbing, Janeway lesions and splinter hemorrhages, or Osler's nodes and Janeway lesions? Think about it for a second. I'm giving you a chance to make a call here. Okay, let's move along. So the key one here is you'd look for pallor and clubbing. And the reason is that Janeway lesions and Osler's nodes are extremely rare. Splinter hemorrhages, obviously, you look for, but the key one is pallor and clubbing. And the reason that, and there in that picture of somebody's eye on the conjunctiva, you can see two little petechial hemorrhages, and sometimes that's all you get as a sign that there was an embolic phenomenon. But these are those things. So there's splinter hemorrhages, beware of the distal ones, which could be due to trauma. Osler's nodes are painful and they're on the fingers, and I've seen them 2 or 3 times in 40 years. So they are vanishingly rare. And Janeway's lesions also, if you look for them, you'll find them, but again, not common and, exciting if you see, but not really the most likely thing. The most common presentation of somebody with endocarditis is that they're pale and they're clubbed and they have a murmur. And anemia and clubbing really do fit together in a place where you would say this is mitral regurg. There isn't a anemia-related flow murmur. Let's look very hard and think very hard about endocarditis. Right, let's change tack a little bit and think about a peripartum patient who's 19 years old. She delivered a healthy baby. She was a little bit short of breath during her pregnancy, but now she's quite dyspneic. There's no edema. When you examine her, she's thin. She has an undisplaced apex, a normal ECG. This is a chest X-ray. Right, now the question is what necessarily is wrong with her, but what physical exam is waiting to be done? What step is the next thing to do? I promise you it's extremely valuable. The first time you do it and find it positive, you'll be a convert for life, because it really is amazing when you hear it like this. So there we go. It's a prominent left atrial appendage. That little bump down there on the side says this patient's got an enlarged left atrium or high left atrial pressures, probably from mitral stenosis. You can see that on the echo there. So you listen carefully at the apex with the bell, with the patient rolled in the left lateral position. Do not say you have examined somebody's heart and it's normal if you haven't rolled them on their left side and listened at the apex with the bell. There isn't always time to do this, but that's fine. Don't write it down that it was normal if you haven't, say, not examined properly or not examined at all, but don't pretend that it's finished if you haven't rolled them on their side and listened. The first time you hear a mitral stenosis in that position and in that position only, you become a convert. Right, this is another one on murmurs just for fun, but the key thing here is that a lot of the stuff we taught about murmurs is sort of right, but you can track it out a little bit. So the top set of pictures there shows where you would hear the murmur in people with aortic valve disease that is significant in terms of stenosis. So you tend to find people with aortic stenosis that's severe will have murmurs that are heard all over the precordium from the aortic area right down towards the apex. It may be a little bit more located like the purple one. Occasionally it's apical only, and beware of that. And the isolated basal one is actually relatively common for severe aortic stenosis, although it's quite common with the more mild forms. The same sort of pattern happens with mitral regurg. The severe mitral regurges tend to be spread up a bit. They aren't just confined to the apex. And I think that's something that's not necessarily always taught at med school. Remember that if you diagnose somebody with aortic stenosis or mitral stenosis, you want to steer clear of the enalapril and other vasodilators. They need their preload, and they need to be able to push out stuff through a narrow aperture. So vasodilating them basically increases the gradient across that valve and crashes the blood pressure. We've seen a few who've come in unconscious with hypertension, and all you have to do is wait for their enalapril to wear off, and then suddenly they're walking around the ward again. So watch out for that. And this one I've already talked to you about, but that picture says it all. So you don't have to see the chest x-ray with a calcification around the pericardium. You can look at this chap with ascites, and you can see that his JVP is elevated, and therefore he doesn't have cirrhosis. He has something else going on, either heart failure as well, or constrictive pericarditis, or something of that nature. So just think of that thing, and the JVP is not to be ignored. It really is worthwhile. Try and write it down, try and look at it. It really, really helps. And this is a very sobering study from Ireland, where they found that when they reviewed a whole bunch of case reports, 50% of patients had no JVP recording during the entire hospital stay, and 3/4 of patients where we messed around with either diuretics or fluids, still nobody bothered to look at the JVP. So think about it. It's really tricky. I struggle after all these years to know what's going in terms of deciding how much fluid and diuretic to give, and that's with looking at the JVP. Doing it without doing so is really asking for trouble. So enjoy your JVPs, and his would be quite exciting because it would have a prominent X and Y descent. It would really flicker and be easy to see. And the other common JVP that you see is the one with his right-sided pressure problems, cor pulmonale, any severe heart failure patient. They have a prominent CV wave where it's all blurred together. So there's just two waveforms really that you need to know about. It's not as complicated as people make out. And then the other one, while we're in that area of the JVP, don't forget about hepatojugular reflux. This is very different to hepatojugular reflex. You don't want to press on the liver. You want to press on the abdomen in general, away from the liver, and the blood in the liver and in the IBC then gets pushed up and gives you a raised JVP. And it's not only a useful sign of heart failure being present, but it actually has prognostic value as well, as that thing shows. So it really is worthwhile just trying it. Pressing on the liver itself is sore, so just push on the tummy away from the liver. And if the JVP is elevated by more than 3 centimeters for more than 15 seconds, you've got a positive abdominojugular reflux. This is the last one on the heart, but just this is a fun little thing. It's a disruptor. It's a study from Eastern Europe, and it's a lone study, so there's nothing yet supporting it. But just in general terms, the clue here is that if you say, I can never feel the apex, try putting patients in the left lateral position. It really does help. Sometimes you can feel it then, and if you can feel it very clearly over a largish area, it is helpful. And it's probably more helpful than worrying too much about the location or the quality or which interspace it's in. And the general thing here is that if you can feel the apex with all 3 fingers in one intercostal space at the same time, that's probably an area for most of us of about 4 centimeters long. You can measure how long 4 centimeters is on your own number of fingers, but generally speaking, that's got a huge positive likelihood ratio of 24, which means that it's very likely that that patient has some reason for a volume overloaded left ventricle. Oh, somebody's writing on my screen. The issue then is that you can also don't use your ultrasound machine to pick up these valvular things nowadays. So most of you have access to a machine and can basically get there in terms of seeing the simple pathologies on the screen on the ultrasound. So don't forget to use these machines. They're readily available nowadays and are well worth a try. All right. Okay. Then the next one is a stethoscope is not a patella hammer. I think that a lot of people seem to think that if you can bang something and get a reflex, then whatever you use to bang it with is a patella hammer. That's not actually how this works. Firstly, it hurts your fingers and the patient. It's not designed for this. Secondly, it breaks your stethoscope. It's not designed to be used as a hammer. And thirdly, it's incredibly insensitive for the thing where you want sensitivity, which is in areas of hyporeflexia. And so if you're really struggling to get a reflex, don't fiddle around with your stethoscope. You might as well not use it. And there is some data on this. There's a study showing that you have to bang harder. There's a lot more force required to elicit reflexes in people who are hyporeflexic. And three hammer types, the queen squares, the long one with in our practice, that white floppy handle and a rubber thing at the end. And then the tomahawk is the tailor one at the bottom. It's got a short, rigid handle. There's a lot of those floating around. They're very, very light. And there are even ones that don't have the triangle, but just have a straight bar at the end there. They're practically useless in terms of eliciting reflexes. So if you use those, you'll probably find your success rate with getting reflexes is disappointingly low. So you stop doing reflexes. Rather find where those big hammers are or get one yourself. They're not expensive, and start using it, and you'll be delighted to find that you pick up more reflexes than your friends. And if you say, well, why bother to do reflexes? Let me give you a case scenario. How about a patient who's admitted with a pneumonia, elderly, and 3 days into their ward admission, the nurses call you because they've now lost consciousness and are drowsy and difficult to rouse, and you go along there. Everybody else has said, we don't know what, let's send them for a CT. The sisters say she was fine at breakfast, but by 10 o'clock in the morning, she was like this. And you do her knee jerks and realize that one of them's brisk and the other isn't. You've worked out what's wrong. She's had a stroke, and you don't need to send her for a CT. So there is value in these things. I don't know how to get rid of my little red line, I'm afraid. I don't know if it's on everybody's.
I'm busy Googling it. Apparently there's an annotation setting somewhere I can't find. So you just continue. I'll see if I can find a way to get rid of it.
Okay. It's fine. There we go. I think I'm going to do it. Let me see. Now that you told me, there we go. And there's somebody else has put another one on. Please stop. Right, there we go. We're all done. And let's carry on. So the next thing to talk about is testing strategies in the lab. And here, the fun thing is that you always are getting these. It's a result that you're not really expecting and what you do. And it depends on the test and what you're expecting. But quite often, the answer is repeated. And people do another test that's similar, expecting help from that. The key things are the green and the purple. Ask for help rather than just repeating a thing that's weird. It doesn't always make sense with the diagnosis you've got, and revisiting your diagnosis and thinking about how that test performs may make a whole lot more sense than doing another test. But if you look at our sort of epiphenomenon of what happens in our health system, when somebody has a weird result or an unexpected result, nearly always the answer is not think about what's going on, try and find the gist of the problem, re-examine the patient, take your history again. That doesn't happen. Everybody says do another test, including the registrar you phone at FREA or CMH or wherever your referral site is. So watch out for this and think about it. And when you're puzzled, revisiting the diagnosis and reviewing the way the test works makes as much sense as just repeating it, hoping for a different result. Einstein said something about that. I'm not going to spend long on this because it does look confusing, but there's just 2 points. It's about test performance. Every test has a sensitivity and a specificity associated with it, and it is worth thinking about these things sometimes, but frequently knowing about those can make you understand how to interpret the test, and not knowing about them can be quite confusing. Then the other thing that people forget about is the difference between accuracy and precision. So the top left target there is accurate. All the little shots are around the bullseye, but none of them's in the bullseye. The precise one, they all cluster together, but again, they've missed the bullseye. What you want is tests that are accurate and precise. And by tests, remember, we can talk about history and examination as well as things that are done in a laboratory. All right, so here's some examples. Remember that potassium results have a whole lot of things that sway them. How the blood is taken, whether it hemolyzed a little bit in the tube, how long it took to get to the laboratory, whether it got hemolyzed in the laboratory as well. All of these things are possibilities which can affect results. And so you need to think about whether you're going to get enthusiastic about results which are slightly abnormal or not. And a lot of the time people are messing around with results where the thing is so close to the normal range that it really doesn't make much difference. So this was a study where they looked at survival probability and showed that inside the normal range, really, it didn't make much difference. So if you were squeezing along on the edge, please don't try and fix things that are probably normal, but at the upper end of a range or at the lower end of a range. It's only when they weigh out that you should be paying much attention to them, unless they are critically important. So potassium of 4 in somebody you're managing as a diabetic ketoacidosis is clearly relevant and probably warrants attention. Potassium of 4 in somebody with heart failure who's been on furosemide for a week is another story altogether and far less needing attention. So it's context dependent also. Here's another example of false positives. So this was looking at the probability of people developing rheumatoid arthritis if they had a weekly positive rheumatoid factor. And as you can see, the brown one, if it's as low as that, and this is different units to ours, but basically the ones who just flicker on the positive side, almost certainly those patients haven't got rheumatoid arthritis. It's only when they're getting to be quite strikingly positive that the probability goes up to about 50%. This one I've put in because there's 2 questions here. It's a normotensive 57-year-old lady. She's got clinical features of hypothyroidism. She has a TSH of 0.01 and a T4 of 4. Both of those are low. And what is the appropriate first-line therapy? And I also want you to look at her leg. So think about it. Okay, so the first thing is to get the leg out of the way. That bruising type thing on the front there is in front of the tibia, and it's called pretibial myxedema, and so it doesn't fit with this patient. So I'm distracting you. Patients with pretibial myxedema have thyrotoxicosis, not hypothyroidism, and you just must be careful of that. The issue here is that both your TSH and your T4 are low, and the issue then is you have to wonder about central hypothyroidism. In other words, is there something that's switching off the ability to produce TSH, which should be very, very high, with a T4 that's very, very low? And so you would wonder about Sheehan syndrome type illnesses where the whole pituitary has been ablated by hypotension during peripartum event, and throwing carbimazole at that patient is clearly wrong. They have got a need for the opposite, which is thyroxine, but starting thyroxine in a patient like that drives metabolism and may precipitate an adrenal crisis. So you start by giving them hydrocortisone, or in fact, you start by sending off a serum cortisol and thinking about the diagnosis, and then you give them some hydrocortisone, and a day or so later, you can start the thyroxine. So think about the tests. The unexpected one is sometimes as important as the expected one. And tests cost money, so know what you're asking for. A 34-year-old HIV lady, a negative lady, presented with tiredness, weakness, loss of breath and breathlessness, weight loss. And she was dyspneic, and she got a bit better when she sat up, and she definitely appeared pale. Her JVP was elevated. She had features of volume-loaded apex and a bit of tenderness over the liver. And there's some blood results. All these tests were sent off before we saw her. Hemoglobin is 13 in spite of her appearing pale. White cell count is normal, and she has a mildly elevated ALT and AST. A CRP isn't elevated. The ESR was done as well as the CRP, and is mildly elevated perhaps. And then somebody did a CEA on her as well, and a TSH. So where do you go here? So the first thing is to say, well, hang on, what's going on here? She sounds like, from the clinical examination and the history, as if she's got a cardiomyopathy or some other cause for heart failure. And in a patient who's got heart failure and is vasoconstricted, she may well appear pale. So when we've got a HB back and it's 13, and you could have done a ward HB to get that information, and quickly too, then should we not just go ahead and treat her as heart failure and see how she does? The little spin of bloods down there will set you back, or set the health system back, about 500 Rand. So we have to think about these things in our era of cost containment. The TSH almost never is helpful in the situation of somebody who's ill. If you ask endocrinologists what to do with mildly abnormal TSHs in a sick medical patient, they say repeat it in a month when the medical thing is better. But the CEA is of interest, and that got this poor lady a whole oncological workup, unfortunately, because of this piece of information which was missing from people's knowledge. You can actually use a CEA as a measure of prognosis in heart failure, and all of those tests tend to rise in patients who've got heart failure. So you must know what are the cause of the false positives before you do the test. Just throwing tumor markers at people with heart failure, unless you specifically want to waste state money and use them as markers of heart failure, is not worthwhile. Tumor markers are basically meant for monitoring response to therapy, not for diagnosis. And we can come back to that. Okay, I'm rattling along because of time, but I just want to spend a second or two talking about something else. Any thoughts on this? And again, I'm not picking on people, but just think about this and see if there's anything there that doesn't make sense. You've got a picture of somebody's heart on an echo or an ultrasound, and you've got an ECG. And if you think about it, what doesn't fit is that the voltage here isn't high. You've got a patient who looks like she should have a hypertrophic left ventricle. And if she has a hypertrophic left ventricle, the voltages should be reflecting that. It isn't a non-standard ECG. The voltage calibration thing suggests it's done correctly. So there's just not much stuff coming to the surface. And that makes you wonder whether this is muscle or something else. And the short answer to that is that that's a patient's heart with thickening secondary to amyloidosis and not secondary to hypertrophy from left ventricular muscle damage. And then another thing that traps us is this. So one of your colleagues might pop this X-ray in front of you and say, is this active tuberculosis? When you get X-rays, enjoy looking at them. Don't just say, oh, I've got to make a diagnosis here. This is a classic, and it shows this thing called eggshell calcification, which is highly suggestive of silicosis. So instead of saying, is this tuberculosis active, you could ask a different question, where did she contract her silicosis, and what is her lung function like, and is she a candidate for compensation if her workplace was the cause. Then there's the round thing in radiology. And there you've got that round ball in a mobile semi-sitting X-ray. And the mobile semi-sitting tells you something. There's a heavy smoker. There's been some weight loss. And colleagues tend to send off sputum cytology and tumor markers in this patient. But the fun thing, which I'm sure you all know, is that there's two round things there. It's a sitting mobile X-ray, so the patient was probably in heart failure. There's bilateral pleural effusions. There's a big round heart, and there's this big round ball, which is called a vanishing tumor. It's fluid in the fissure, and as you diurese the patient, you will magically find that the pleural effusions at the bases disappear, and this little ball goes away too. So just a bit of furosemide is the best way of dealing with this particular tumor. Right, we're just going to end off on the radiology side of things with two quick X-rays or quick thoughts. And one is that not everybody needs a CT scan. Now, I'm not saying that this patient didn't benefit from the CT scan showing cerebral edema, but it's not always the most sensitive way of diagnosing it. And a study done some years ago showed, this was in children where they were actually monitoring intracranial pressures, and showed that the radiology assessment of raised intracranial pressure had a sensitivity and specificity of only about 50%. In other words, it really wasn't a good way of doing it. Are there better ways? Well, this has been around now as a technique for more than 15 years, and most of you have access to some form of probes. It won't work with a gynae probe, or abdominal ultrasound probe, but some of the other ones, the echo probe or one for putting in lines, will show you this. And what you do is put some jelly on the eyelid, on a closed eyelid, and then have a look, and you see wondrous things. So the papilledema is the one in the middle, which is what I'm giving up on trying to persuade people to look at with a ophthalmoscope, because everybody's ophthalmoscope seems to be broken these days and nobody knows how to switch them on. But you all know how to use your expensive ultrasound machines, and the bottom right picture there, the transverse line which goes across should be less than 6 millimeters. If it's more than 6 millimeters, you've probably got raised intracranial pressure. And this is very practical. So if you're wanting to see whether to do a therapeutic lumbar puncture on somebody with cryptococcal meningitis, and the width of that optic nerve is 7 or 8 millimeters, then you almost certainly have got a patient who might benefit from a therapeutic LP with a pressure monitoring device. And we can talk about giving sets as pressure monitoring devices too. They work fine. I'm going to move on to the last little section, which is a bit softer than the bits I've done already, and really want to focus on writing notes. And remember that when you're writing notes, if you can be focused and pertinent and avoid repetition, it really does help colleagues who are trying to read them. And remember, they are a communication tool. They're not to say, I was here and I did some work. It's to say what you found, what you decided to do, and what other plans you have for the patient going forward. From a medico-legal perspective, though, please write down the patient identifiers, the name, folder number, and don't forget the time. Not just the date, but the time as well. This is starting to become critical with some of these cases that we've seen, where it's unclear from the notes whether the patient was seen within 5 minutes of being referred or 24 hours later, because the date's the same. Please be legible, and please write stuff that's defensible. Don't be rude to your colleagues in the notes, and say stuff that makes sense. That one on the right, for those of you who want to read it, is a genuine script. It was dispensed. It says Rifa 4 or 5 tablets daily, moduretic for those of you who like that, 1 a day, furosemide, that's Lasix. I believe that's 40 milligrams, but it's a little difficult to tell from those two squiggles. And digoxin, half a tablet daily. Please do better than this. This is a colleague of ours. So I'm going to move on to prescribing now. And the issue here is really fluid prescribing is just as much of prescribing as medicines. And when you're talking about IV fluids, remember they're for all those uses, resuscitation, replacement, maintenance. Try and understand where the patient's hydration status is. A history of diarrhea is very helpful. Skin turgor isn't. This is a paper from 1999, which basically says all those physical signs that you were taught are hardly worth the teaching thereof, because they really alone achieve very little. When you combine them, they might do something, but it's very difficult to assess hydration from the foot of the bed, which is what a lot of people try and do. And do try. Postural changes in pulse and BP are insensitive, but relatively specific. So think about looking for those. In the elderly, it gets even more difficult. I'm not going to spend time on this other than the purple line, which is skin turgor, which is worse than useless, literally, and shouldn't be even mentioned in somebody where you're assessing hydration in the elderly. Passive leg raising, there's a case for that. We could spend time on that in the sense that it's nice to do it, but do it properly. If you have a fancy bed, it makes it a lot easier. But you can use the blood pressure to see whether you're getting fluid responsiveness. So if the blood pressure does go up, you probably would benefit from giving the patient some fluids. Blood products I'm not going to spend time on. They're gloriously expensive. As you know, a unit of blood nowadays is over 2,000 Rand, and the cross-match brings the total up to well over 2.5 grand. But here's two patients, a 29-year-old woman who's a vegan, she's tired, she's wandering around outpatients, she's got a bit of edema, HB's 4, MCV's 120. And then on the other side, you've got a 76-year-old man with background ischemic heart disease, brufen abuse, tachycardia, borderline blood pressure, and hemoglobin of 8, and your surgeons say the transfusion threshold is 7, therefore he mustn't have blood. So which of these two would you give blood to? Well, the short answer is I wouldn't be inclined to give it to the one with a chronic anemia who's ambulant. I would be very worried about this guy who's got borderline cardiovascular signs and who may not have had his ulcer tied or his bleeding stopped, which is where that story came from. But here's just a little detour via the begaloblastic anemia. Remember that the smear gives you a very rapid answer sometimes. If you see a multinucleated neutrophil in a patient with a macrocytosis, it's usually B12 deficiency and very easy to manage. If you see somebody who's bleeding, this is not when the restrictive strategy works. It's when the bleeding has been resolved that giving blood to people with HBs above 7 seems to cause problems, and it may increase mortality. But just be careful of not transfusing people who are still leaking. So these thresholds do vary. I'm not going to spend long on rational prescribing. Make sure your diagnosis is correct. That script in the bottom has got 4 ticks on it, which are the pharmacist having dispensed those 4 medications, which are Moxil, metronidazole, doxycycline, ciprofloxacin, and chloramphenicol eye drops. And I only got to see the patient because they didn't have any ciprofloxacin. The doctor had gone home and they thought maybe I could tell them what to substitute for it as the 5th antibiotic. And essentially the patient had an allergic or vernal conjunctivitis and went home with some simple iron medication and a history. Made that diagnosis. So be careful what you're doing. Think about our prescribing environment and try and avoid prescribing misadventures. I'll come to that now. and try and get some concordance going. In other words, that the patient and you must be on the same page about the treatment. Don't just worry about adherence. You should see what the patient wants, not what you think they ought to have. So this is a straightforward one. I hope you can all see that in this day and age. 20 years ago, it was a problem because people didn't recognize it. It's a prolonged QTC, and the patient had this collection of medicines. And actually, we saw her in Torsade. She was in VT at the time, although she was fully conscious. And it really was a mixture of azithromycin-type medication, macrolide, plus a couple of antidepressants. And that combination was potentially lethal, as we found out during COVID, although people thought it was a good idea to give chloroquine and azithromycin to folk together. This should show you what can go wrong if you don't ask to see the packets. Check your prescription for logical inconsistencies before signing it. Stenocot 2 stat and thereafter 1 after every loose stool doesn't make sense. Again, the alarming thing there is a signature from the dispensary. Okay, so it won't always get caught by somebody else. Be careful. Do read them. This is another one, and please don't do this. I see one of these almost every year, KCL 1 amp IV stat, which is how some of the US states used to do their formal executions, and it is going to knock somebody out completely and has done so. So, you need to write it out carefully. 2 ampules of KCL, 40 millimoles of 20 millimoles per amp in a liter of saline. You mix it thoroughly and infuse it and see where you go from there. Please try and get that into folks' heads. Many of the hospitals now only allow the pharmacy to do this mixing, which is probably not a bad idea in some situations, but problematic over weekends. And ask to see the packets. Okay, so this doesn't look too bad. The inset here shows that the warfarin 5 milligram bottle had no warfarin inside it, but was filled up with glorious paracetamols or antihypertensives. I can't remember which, but certainly had nothing inside there that was going to anticoagulate the patient. When you're writing units and decimal commas, please be carefully. Write micrograms rather than that pretty mu, which often gets mixed up with milligrams. And don't use dots, they get lost. Use commas. So write 1 milligram rather than 1.0, which could be 10, and write 0.1 milligrams rather than with a naught in front, because the comma gets lost again. So you put noughts before the decimal commas, but not after, is the aphorism. And avoid trade names. Asavent and Atravent can look very similar. One works very differently to the other. Right, so I'm going to finish off then by just running through a couple of things about getting reliable information. Now, guidelines are the best way of doing it. The problem is whose guidelines? There are a lot from the Department of Health, from the EML, from interest groups. They vary enormously in quality and local applicability, particularly the international ones, and they are often very long and quite difficult to read. So, one tends to veer around to stuff that you find quickly on the internet, and there's some problems with that. Beware of narrative reviews. A lot of the stuff appears okay, but in fact isn't. Nowadays, some of it is generated by AI, and it's not always applicable or of good quality. Primary articles are worth reading, but again, sometimes can be difficult to find. I'll just give you one example here. Here's a thing from a thing called Stat Pills, which is a version of one of the previous Medscape e-medicine type things, and it's a commercial site. And the bottom line of it is that there is conflict of interest amongst many of the authors, but they also don't have to be particularly qualified. Some of them are very good, some of them aren't. As an example, here at the bottom, it says how you should use a stethoscope. To use it as a patella hammer. and it gives a reference. And if you chase that reference, you'll find rather delightfully it's an article written as a letter by a surgeon who thought it would be a good idea. No evidence behind it whatsoever. So be very careful when you read these things. They may sometimes look very plausible, but are complete rubbish. Right, the last thing then I want to talk about very briefly is medical enthusiasm. This is about avoiding burnout and keeping some job satisfaction. I know it's not strictly internal medicine, but it applies so much to the folk that I deal with that I thought it might be worth a little bit of time. And one of the problems is moral injury. As you all know, I'm not going to spend time on that. It's common because of the space we work in, and the predisposing factors, as you know, are our workload, not having enough clinical support from folk with more experience, not enough resources, patients don't do as well as we'd like them to, and there's a discordant inter-individual work ethic and clinical enthusiasm, which is a polite way of saying not all colleagues work equally hard or seem equally interested in what's going on. And that can be very frustrating at times. And there's often a disjunction between what you can achieve in your rural practice and what you thought was the expected standard of care in a tertiary hospital. And that's something that's very close to my heart. We don't do badly here. We do as well as we can, often under the circumstances, and that's okay. It doesn't have to be tertiary medicine for everybody. And we often have a perception of lack of agency. You can't fix anything, but in fact you can. And often you feel isolated. Nobody seems to be taking you seriously. So those are some of the things that come up. There's a whole lot of sites you can go to looking at things to fix this, and it all looks very simple and easy, except it's almost impossible to do, except for this thing right at the bottom here. You can work on your local organization and redesign some things locally, which can make a difference. And how you generate enthusiasm when folk around you are losing theirs, really. Use positives to point out negatives. Don't snipe at everybody else. But when something is wrong, don't leave it, but try and frame it in a positive way as possible. Don't let it slight. And when somebody gets something wrong, and I'm including nursing right, when the nurses get something right or a colleague gets something right, tell them. It really is worthwhile. And if that sort of thing starts to happen more, it really does help the team work better. The other thing is keep reading and learning and share what you've learned on a daily basis. If you find out something fascinating and interesting, pass it on. Teaching is a massively effective way of sharing enthusiasm and fostering clinical interest, and find areas where you can have agency. And it's not all medicine. Have an escape activity as well. So I'm going to remind you then about two things here. Beware of driving around when you post-call. I know this is a tip that's got nothing to do with internal medicine, but everybody is post-call and they think they can drive with their cell phones going, but this is where the accidents happen. So watch out for these things. Remember that you are not at your peak after being awake for 24 hours, and take a break, chat in a group, and manage your workload as much as you can. Right, so we're finishing off then. Why do patients with these symptoms present now is on the history, and it's all about thinking of diagnoses, avoiding biases, and when you come to examining, don't be ritualistic, look for high yield things, and remember to look out for things that should be there but aren't. It's sometimes useful, and what tests will confirm the diagnosis, allow safe management, and assist with review, not just I need to do a bunch of tests. And does the treatment address the key problem? Is it safe? Is it necessary? So these are some of the things that might make medicine worthwhile. We turn an undifferentiated illness into a useful diagnosis. We interact with ill people and accept their trust. We see people getting better. We can learn all the time, and you can teach all the time, and you can be part of a team. And I hope those are some of the tips that might help you. They've certainly helped me. I really, really appreciate this opportunity of talking to you all, and I'm very happy to take a question or two if there are any. Thanks very much.
Thank you very, very much, Prof. I love all the little tips. It's always very inspiring, the little things that experts pick up over the years, and especially in terms of teaching clinical reasoning. Quite often we are we go to lots of presentations which focuses on giving us content, but quite often it is about how do you put all of that information together. And I was really happy with your little chat about medical enthusiasm. Some of you might have been at the talk we did a couple of weeks ago that was around how do we create supportive learning environments. And I really do want to enforce that you will never know everything. If you feel like listening to a presentation, you get a little bit nervous because there's, gosh, hard sounds is a bit of a challenge for you, or specific things leaves you a little bit at a loss, is we really need to create working environments where it's okay to admit to mistakes and it's okay to ask what feels even like a stupid question. And I think Prof Parrish has always been amazing in terms of how do we create those safe spaces that makes us able to talk about also the areas where we're just not so sure about. And I see even now, it doesn't matter how long you work in a particular field or particular area, there's always those patients are going to stump you, or things that's going to leave you puzzled, or things that you are suddenly confused about that seem straightforward at the time. So I think that's a helpful way to go forward, is really to start using our resources. If anybody has any questions, you're welcome to put them in the chat. You will have noticed I've put up a poll. We need that for HPCSA compliance rules these days. If for some reason you can't see the poll, please put your name and MP number in the chat. But if at all possible, please do fill in the poll. You can also put up a hand if you want to ask any questions or have any particular things you would like to comment on. While people are thinking, I'll punt next week's presentation so long. So next week is our last presentation. And Dr. Julie Switala is going to come and speak to us about the new pediatric TB guidelines, and particularly looking at how we implement them within our district and CHC rural settings. So that should be very exciting. She, I think, was actually involved with the actual writing and launch of the guidelines. And so that will bring our rural onboarding to a close. Andy, I'm not seeing any hands at the moment. I think there's lots of food for thought. So yes, so I think we can then close this evening. We're exactly on time. Thank you very much, Prof. And I do hope that we can invite you to some of our future webinars, and definitely at our future rural onboardings. All these little pearls of wisdom that we still have access to those in the future.
Oh, thank you. It was great chatting to you all, and I really wish you all the best. It really is a worthwhile space to be. It's often very challenging. I really have been where you guys are at the moment long, long ago, and I still think it's one of the bits you remember best about being a young doctor. So enjoy it and learn from it, and I really hope you have a great time out there. Thanks very much, guys.
Thanks, Andy. I'm going to say good night, but I'll just keep it open for another few minutes